When we talk about vulnerable populations, all right, ta-da, yay, okay, now we're good to go. When we talk about populations of kids that are especially vulnerable, so you think about, for example, kids who have been in conflict situations like Syria, or you think about kids in the United States who have been abused and neglected and are now in the child welfare system. The rate of mental health problems increases up to 50%, in fact, in those populations. But the reason why I call it a 2020 population, and you may have seen the NBC News series 1 in 5. Every once in a while, they talk about how significant a problem of mental health problems. There's an interest. One of you mentioned an interest in suicide. So the concern about elevated suicide rates among kids these days. But unfortunately, even though we have a number of wonderful programs that are designed to address these mental health problems, whether they're cognitive behavioral therapy focused programs for dealing with depression or anxiety, like Coping CAT or multisystemic therapy, or there are programs that are designed to train parents in how to raise kids so they don't have mental health problems, like the Incredible Years or parent-child interaction therapy. Only 1 out of every 5 kids who need mental health services get those practices. And in fact, in the U.S. Nationally, about 20% who need the services get them. When you think about kids who are in public mental health or public child welfare systems, it may only be 10%, because 90% of systems use something, but they're not necessarily using something that's evidence-based, or if they're using something that's evidence-based, they're not using it with fidelity. In other words, they're not using it with the way that the developers of the intervention intended. So the end result is we've got a disconnect between research and practice, and that's due to a variety of factors. It can be that to do a CBT takes a lot of time and resources, and you may not have 12 weeks to work with a kid when their insurance may, if any, pay for 4 weeks, for example. The practitioners are not necessarily trained well enough. They don't have access to the peer-reviewed journals that much of the work that we do ends up getting published in. And they don't get any, extra pay or incentives for doing these evidence-based practices. So they ask themselves, what's in it for me? Many times the logic and the assumptions that go into the design of the RCTs that demonstrate the effectiveness of these don't match real-world conditions. So the problem of external validity, we know it works, we know it's because of the intervention, but when we try to apply it to a real-world clinic, not so much. And the lack of relevance to specific populations. So something that may be developed for white middle-class kids in Topeka, Kansas, may not work so well here in the Bronx, for example. With a very different population. Many clinicians, those of you who are clinical psychologists, know very well that if you're trained and you're sent out into the world, you're expected to know what to do. And people generally don't like being told what to do. And so when somebody hands you a manual and says, now start treating kids this way, the concerns about lack of control may be a form of resistance to actually using the practice. And then just not having adequate support, either from the leadership or capacity, the staffing and so forth, creates problem as well. So what ends up happening is by the time you develop your interventions to the point where people are actually using it, could very well take 17 years. And you think about all the process that goes into identifying a priority for funding, peer reviewing of grants, submitting, resubmitting, developing a research synthesis, establishing guidelines, and so forth. It can take 17 years. Well, you know, these kids can't wait. In much the same way that your HIV clients can't wait for many of the kinds of interventions that you're considering to develop. So when you think about the pipeline that occurs between the point where you come up with a great idea for a new intervention to the point where it's routinely used, you're asking yourself three questions. Could a program work? In which case you develop studies to determine whether it's efficacious. You know, do I get the result I think I'm going to get? Does the program work? Requires more effectiveness studies, which are conducted in real-world settings, to making a program work where you go through the steps to successfully implement. And it's really in that last area that most of my work has been focused on. So the field of implementation science, as it was described by the authors of the journal Implementation Science, which has now become the flagship journal of the profession, is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practices, thereby improving quality and effectiveness of health services. So it's not just a matter of identifying what the problem is, why aren't people using these evidence-based practices, but it's a matter of coming up with a strategy or solution to get those practices into routine use. Now, I'm not, you know, I certainly don't have the time to go into the history of implementation science, and that's really not my intent here. And I'm trying to distill into an hour what took me, 3 hours to talk about in Bangkok. And I promise that as soon as I start seeing your eyes glaze over, I'm going to stop so we can have questions and answers. But I just want to, as an overview, tell you that there are 4 essential pillars to the field of implementation science, 3 of which, or 2 or 3 of which I'm going to talk about today. The first having to do with theories, models, and frameworks. This is really what drives or provides the conceptual framework for the work that we do. And there's a variety of them. Some of them have taken off much more than others. In fact, I think at last count there were about 90 different frameworks for implementation science, so much so that the field has said enough already. You know, we kind of figure out that they all talk about the same thing. Let's kind of move on if we can. But the fact is, they're critical to understanding, you know, what the nature of the problem that we're trying to deal with and giving us guidance or directions on solving that problem. Second is implementation strategies. And as I said, like the train the trainer model or cascading diffusion, this is the set or the tools that we use to get things that are evidence-based into practice, into routine practice. So many of them are involved in getting people trained and then having them train others. Others, like the breakthrough series model or the community development team model, are really based on bringing people together who have, you know, are facing a common problem and giving them the tools to solve that problem collectively. The idea being it's much more efficient to do that than when you try to do it individually. And then there are some very extensive, elaborate strategies that involve preparing organizations, you know, getting them ready to adopt and use routinely and sustain an evidence-based practice. Another pillar is that we've developed our own measures for evaluating whether we did it or not. So it's not just a matter of, ensuring the effectiveness of the intervention, but ensuring that it's routinely used. And how do you do that? And I'll talk a little bit about these different types of methods that involve focusing on both the outcomes as well as the process of implementation. And then finally, the methods that we use, which range from the use of mixed methods, which some of you expressed an interest in, to alternative forms of randomized controlled trials, because many times the classic RCT model that we've been trained in just really doesn't work very well in a real-world setting. So you have to do something scientifically rigorous, but in a slightly different way than the classic RCT. Or the use of community-based participatory research methods to bring together researchers and practitioners and policymakers collectively engaged in the task of implementation. Or increasingly, system science methods like social network analysis is being used as a methodology in implementation science. So let me tell you a bit about theories, models, and frameworks. About a year ago, I guess, Gina invited me to come to a workshop that she was hosting, and I got a little bit into it with, in fact, one of my colleagues from USC about the distinction between a theory, a model, and a framework, because we often use those terms interchangeably. But they're really very distinct things, and they have very distinct uses. So you think about why we use them in the first place. They help us understand why innovations, evidence-based practices don't work, or why they don't get implemented successfully. They help us determine how to get them successfully implemented by either generating testable hypotheses or identifying the right implementation strategy, because there are many different kinds of implementation strategies that are out there. So when you think about a theory, think about a set of analytical principles or statements that structure what we observe and how we observe it, but also give us an understanding or explanation for what it is we're seeing. Why is this occurring, or why is it not occurring? It helps us to understand why something works or happens to be the way that it is. A model, on the other hand, can be a theory, but it's got a much more narrowly defined scope. And whereas a theory is explanatory as well as descriptive, the model tends to be more descriptive. So it tells you what's going on, but it doesn't necessarily give you the tools to understand why it's occurring. And then a framework, which has been what a lot of people in implementation science have been using, is, when you think about the framework of a house, it's really to provide a set of instructions for how you put it together. And in this sense, the frameworks don't provide explanations, but they describe all the tools, all the elements of the house that you're going to use to build. So that implementation science frameworks are really focused on understanding all the variables that predict implementation. But they don't necessarily tell you which variable is more important, or they don't tell you why those variables are important. So the most, perhaps in the history of the field of implementation science, the one that we rely on and treat as our ancestor is the diffusion of innovation theory. And this was developed by the sociologist Everett Rogers. And those of you who may know the name may not know that he was what was called a rural sociologist. There was a subdiscipline of the field in which people, in fact, Iowa State University was the leading center of rural sociology, as you can well imagine. But Rogers was studying the diffusion of different forms of hybrid corn back in the late 40s and 50s, and how that process, how farmers came to adopt a new way of growing corn that was much more productive, you know, elevated their income and much more resistant to bugs and to drought and so forth. And what he found was that, you know, every county in Iowa, every county pretty much in the Midwest has an agricultural bureau which sends out agents who talk to farmers and give them advice about how to get the most out of their land, how to get the most out of their crops. But he started noticing that when an agent went into a particular area or community and started talking to one person about trying something different, they in turn would start talking to their neighbors. And so he started tracking the patterns of communication and the networks and realized that there was more method to the madness of doing so. So that the key elements involve having an innovation and looking at its attributes. So what was it about seed, you know, hybrid corn that would be appealing to these people? Looking at the social system, you know, how farmers are aggregated or how, you know, ID drug users are in a community may interact with one another, the period of time in which those interactions occurred, their own perceptions of the favorability or the risks associated with adopting a new behavior, the interactions that occur, and then the influence of those interactions as they occur. And so what he found was that anytime you adopt a new practice, you can see a bell curve of responses to that practice. So there will be some people who really like the idea. I mean, the missionaries, the innovators, people like yourselves who are developing these new practices. But you're going to find some people, about 13, 14%, who really like the idea and really want to jump forward. And they also tend to be people who like every idea and are the first to jump in feet first. But most people tend to think about it, and it takes time for them to think about it and become influenced. And then there's about 15, 16% who are never going to do it, no matter what you tell them or what you try to convince them, the laggards. And so how you communicate a new intervention may differ depending upon who you're communicating it to. The message isn't always going to be the same for every member of your proposed audience. So the process goes through this innovation decision-making process where you introduce it, people think about it, they try it out, they may like it, they may not like it, but and if they like it, they may communicate it to other people or introduce it to other people. You can imagine that that process is much shorter for the early adopters than it is for the early or late majorities. And like I said, it may be a waste of time with that 16%. It involves using change agents. So this could be senior individuals within a clinic or organization with a broader view about the benefits of the innovation. And it could be opinion leaders, people that others go to for information and advice, who will say, yeah, this is a good thing, or don't bother with it. But they have a great deal of influence. Now, another major theoretical foundation of implementation science, one that I'm sure most of you are familiar with, social learning theory. Bandura's notion that people are influenced by what other people do and what other people think. And many times the degree of influence is shaped by the similarities between those other people and yourself. So that watching the behavior of others is a powerful influence on your own behavior and your willingness to change, both in terms of the people you want to be like, as well as the people that you feel you're pretty similar to. So, you know, we know that learning is a cognitive process. It occurs by observing the behavior. and that the learner is not just a passive observer, but actively engaged, which is also an important notion behind implementation, because again, it's not just a matter of saying this is how you do it, it's getting people involved in the process of doing it. That's very critical. So those are some of the examples, and those are probably the two most dominant theories that underlie implementation science. There are also several different types of models. Often these models help to give us guidance on the process of implementation. So they may specify various steps or stages that occur beginning from the first exposure that you have to a new program or practice, to planning out how you're going to introduce it into your organization, to actually doing it, to sustaining it. And they describe or guide the process, thereby helping to facilitate the translation of research into practice. One model, for example, Grohl and Wensing developed a 10-step model for introducing changes that were based on the notions of orienting, developing insights, getting people to accept it, changing behavior, and then keeping those changes in place. Another model that is widely used is Green and Coyer's Precede-Proceed Model, where they identified 8 different steps to the process of introducing an innovative practice, beginning with an assessment of the practice itself, socially, going into an epidemiologic assessment, so you've got some data to prove that it's more than simply anecdotal, doing an educational or ecological assessment, administrative or policy assessment, and then after you've done all of those assessments, beginning with implementing it, evaluating the process, evaluating the outcomes, and essentially continuing it up and running. So this was a model initially based on introducing a nutritional intervention, and as you can see, a lot of the models that govern health behavior change provided the framework for this particular model. Another one is the PRISM model. This has been widely used in the VA system to introduce new practices, which takes into account not just the scientific evidence that demonstrates your program works, but the context in which it's supposed to work, as well as an understanding of the mechanisms that make it work. And so this is another one that has, like I said, although it initiated with the VA system, it's been increasingly used in other healthcare systems as well. And then finally, the frameworks. As I said, there are dozens and dozens of different kinds of frameworks. Some of the more widely used include the interactive systems framework, which look at 3 particular sets of activities. One, distilling the information, supporting the work, and then implementing the work. And those activities occur in a broader socio-economic, socio-cultural setting that involves policy, funding, the climate, the will to change, as well as existing research and theory. Another one, perhaps most widely used implementation framework, is the Consolidated Framework for Implementation Research, or CFIR. Now, the reason why this is the framework is because it gives us a great list of the determinants of what makes for success in implementation. And they're broken out into 5 groups. So one of those characteristics relates to the intervention itself. Is that clear? It looks a little fuzzy, but basically, where the information about the intervention comes from, the quality of the evidence supporting it, and then in terms of how useful that intervention is, much of this actually comes from the diffusion of innovation theory. Its advantage relative to other practices, its adaptability, your ability to try it out and see if it works, how complex it can be, the quality of the design, and then most importantly, how much does it cost? And that happens to be perhaps one of the most important considerations that any new practitioner or policymaker will consider. Then there are characteristics of the organization itself and the environment in which that organization exists. So the structural characteristics of your clinic, for example, how many providers, how long has it been in existence, how many patients do you see, the networks that link providers and practitioners within an organization as well as connected outside that organization. The organizational culture, what is our mission? Do we like working here? And is it a place that is considered psychologically safe to work with? Are people happy or are they miserable, for example? The outer setting, supply and demand. Is there a need for this practice? Is there resources that can help support it through funding or mandates that dictate you have to do it? Are other clinics doing it? Those can all be characteristics of the outer setting. The individuals involved, how much do they know about what it is you're trying to do with this practice? Do they feel confident enough to do it? At what point are they ready to change? Are they somebody who's still sitting on the fence? Or are they one of those early adopters that are good to go? And then finally, the process of implementation. Is there a plan in place to implement? Are people following that plan? Who is getting engaged in it? Does the leadership support it? Do you have a champion who can push for that particular practice and be a resource for you? So these are all determinants of successful implementation. And then a final framework that I'll talk about is the EPIS. And EPIS stands for Exploration, Preparation, Implementation, and Sustainment. This has pretty much the same set of predictors of implementation as the CFIR model. But where this differs is that it focuses on the process of implementation more, noting that there are different stages in that process. And with each stage, some of those determinants are going to be more important than others. So as you can see from this, one of its characteristics is that it brings together the outer context with the inner organizational context. And it does so through a set of networks or connections that bring those two together, but also link them to the characteristics of the intervention as well as you, the people who are developing it. The assumption being that those linkages are critical to successful implementation. Now, it's not going to see all the elements in this chart, but it pretty much tells you that many of the characteristics that you saw in the CFIR might be relevant to the stage of exploration, but they might not be relevant to successive stages, whereas some of the things that are relevant to the adoption phase may not have been relevant in exploration or may not be relevant in implementation. Some may be relevant to all four stages. But the idea being that, simply having a list of predictors is not enough. Knowing at what point in that process people are with respect to implementation does make a big difference. So let me tell you a little bit about how we actually go about studying this process and studying the outcomes. So one of the things that I do a lot is what's called mixed methods. And I got into mixed methods because I was, my PhD is in anthropology, as Milton said, and so I was trained as to do classic ethnography, field work, with communities whose cultural background or experience was very different from mine. I was the outsider, the naive outsider. But I realized after I got my PhD, if I was going to be employable, I needed to know something about numbers. And so I did a postdoc in epidemiology. In fact, I was a hair's breadth away from actually coming to Columbia to get my MPH and do a postdoc with Barbara Dornwind, who probably some of the old folks from the blank stares of all the younger people. Anyway, but I ended up doing it at a research center that was supporting the U.S. Navy. It was based in San Diego. And I figured I couldn't live in New York City on $14,000 a year, unless I was on the streets, I suppose. But anyway, that's where I learned how to do epidemiology. And the fact that I could translate numbers to my qualitatively oriented colleagues in anthropology and vice versa gave me a feel for the study of mixed methods, because it's not just a matter of doing qualitative and quantitative data collection and analysis in a project, but how you integrate those two types of data that's important or critical. So that you think about it in terms of the synergy that occurs when you bring together people from different disciplines. The same type of synergy occurs when you bring together different types of methods. So it's not a matter, and I always say it's not just a question of parallel play, where you've got a research study going on, you've got some investigators doing a survey and analyzing it quantitatively, and others doing some focus groups or interviews, but they're not playing together. That's not really mixed methods. You could call it a multi-method study, but it's not really the integration. That's what defines it as mixed methods. Why do we do it? Well, many times we do it to generate a theory when we don't have an existing theory to base, and even if we don't have an existing framework or conceptual notion of how things should relate. So the qualitative methods can help you generate this theory, and the quantitative methods help you test that theory. Now, the things that define a mixed method study include the structure of the methods themselves. And the structure is defined by when you do the data collection and analysis and how much emphasis or priority you give to each set of methods. So in mixed methods, oftentimes in the study, you can either do them together, collecting qualitative and quantitative data simultaneously, or you do them in sequence. You may begin with a qualitative study to generate the hypothesis, the quantitative study subsequent to that to test it. The weight or priority that you give to those methods. So you'll notice a lot of qual-quan. As you can imagine, the qual is for qualitative, quan for quantitative. But some are lowercase and some are uppercase. If they're uppercase, that means the priority is to that type of study. If they're lowercase, the other type of study is acting in service of or assisting that. So you may give priority to the qualitative methods, in which the qual is in uppercase, or the quantitative methods. But it's also possible, even though there are some people who would disagree, to give equal priority. They're both equally important. They have equal value to the kinds of questions that you're trying to answer. The other thing about mixed methods is that it can be iterative. So that many times going through the asking of or trying to answer a research question qualitatively may generate the necessity of collecting additional data that's quantitative, or vice versa, in which case the process of collecting and analyzing data can go back and forth over the life course, lifeline of a study. So how do you know when to, okay, I missed that one. So in addition to the structure, it's the function. Why do you do mixed methods? One answer is you do them to bring the data together to answer a particular question. Now, it may be that you have a finding from a quantitative study, but it's underpowered. And rather than simply say, I don't have enough power to answer the question, you may supplement the study with a qualitative study and then triangulate to see if you're getting the same answers. Or many times, people will quantify their qualitative data, or quantize it, as the language is typically used, where you transform data from qualitative to quantitative. And you can actually also do the other way around, but that frequently that's a practice that's done. So that would be to seek convergence. Another one is complementarity. So as I said, many times you can take the qualitative information to generate a hypothesis or to explore an issue, and the quantitative method to validate it. Or you can use the qualitative to give you a real depth of understanding of a phenomenon, and the quantitative to see if that understanding is generalizable. How broad does that understanding apply? Many times we use qualitative methods to study the context in which we're doing our study, or the process in which we implement something, and the quantitative methods to study the outcomes. Another approach is expansion, and that is to answer questions that the quantitative data or the qualitative data by themselves cannot provide, but provide some direction or need to. So that you may get a finding from a quantitative study that you can't answer by the quantitative data alone. And just to give you an example, I know Milton and Claude have heard this. Many years ago, I ran a randomized controlled trial as part of a series of studies called the Perinatal 20. This was back when the crack epidemic was a great concern about crack babies, if you remember the terminology. And ours was, I think, the only study, or one or two studies of the 20 that focused on adolescents. And so we had we had taken a social skills training intervention, something that's commonly used these days, and tried to reduce or prevent drug and alcohol use in pregnant or parenting teenage girls. These were mostly 16-year-old 10th graders. And we randomized them into social skills, social network restructuring, counseling by social worker, and a control conditional life skills. And what we found was that the social skills training condition, rather than reduce the prevalence or incidence of drug and alcohol use, actually increased it. So not a great thing when NIDA gives you, $12 million to run this big RCT. So we decided to run some focus groups with study participants afterwards and said, this is what we found, but we don't understand it. The data can't tell us why you were more likely to drink and use drugs. And the girls told us, oh, the intervention worked great. But what they did was they taught us how to connect with people who had access to drugs and alcohol. So that while it may have been with very good intentions, it had you know, unexpected outcome. We would have never known that had we not done the qualitative work afterwards. Another form of use of mixed methods is exploration or development. Not just developing a theory or developing hypotheses to be tested, but you may use qualitative data, for example, to figure out which population should I be targeting. Is it all HIV users? Is it transgender populations that are a particular risk? Is it MSMs, African American MSMs or Latinx MSMs that I should be working with? And what kinds of questions should I be asking them? You know, if I design a survey, am I asking the right questions or am I asking them in the right way? So we may use qualitative methods for that intention. And then finally, sampling. One of the biggest challenges in doing a qualitative study is figuring out who am I going to get to interview. And it's not just who, but why am I asking them to be interviewed? So many times you may find in an article, we conducted a study from a convenience sample of people who just happen to be around and available and interested in participating. Well, there's a little bit of bias in doing that. And it doesn't necessarily, it's not strategic to give you the answers that you're looking for. So we oftentimes refer to purposive or purposeful sampling as a way of identifying people who are most likely to give us the most amount of information that we're seeking. And sometimes we do that through the quantitative information that they provide. So for example, if we want to know who's an early adopter and who's a laggard, we may administer a readiness to adopt scale, and then pick, you know, the top people who scored in the top 5% and people scored in the bottom 5%, and use that as a sample for probing into why they're excited or why they're not excited about a particular intervention. So these are the different types of reasons why we do mixed methods. And when we're trying to find answers to the same question, that's when we use it for the purpose of convergence. When we use it to answer related questions, we're doing it for the purpose of complementarity. When, you know, what you've learned from using one method raises questions that can only be answered by another method, that's expansion or explanation. When you're, the method that you're using needs a prerequisite that requires another method, that's exploration or development. When one method helps to define or identify the participant population, that's sampling. So that, in a nutshell, that's mixed methods. Yes, question.
I just asked a quick question about that. I feel like this all makes tons of sense, but then when it actually goes to happen, it takes a long time, to actually get the findings, analyze the data. So does this happen in the context of one study, or are you talking about over multiple studies?
Well, so you're picking one. I mean, you may have more than one purpose for doing mixed methods, but it can be done in the context of one study, like this, where you've got the qualitative data and the quantitative data, and you're bringing them together. So you're merging them together, right? You're connecting them when you begin with one and then move to the other to get your results. What most of you, who are doing the randomized controlled trials or have the aim of doing that, many times you embed the qualitative data in the larger clinical trial to get your results. Okay? So it's a matter of timing and it's a matter of resources. You're absolutely right. And I'll show you, hopefully, if we got time to show you a short way of doing some of that. So deciding which way to mix those data, when you're seeking answers to the same question, you're merging them. When you're seeking answers to related questions sequentially, you're connecting them, and when you're trying to seek related answers or answers to related questions simultaneously, you're embedding them. So that, basically what I'm giving you is a set of rules for how to pick and choose what it is you want to do and why you want to do it. In much the same way that when you do quantitative data collection and analysis, you want to pick the right tool for the job, right? And the same is true with mixed methods. So in implementation science, we may use quantitative to measure the implementation or the intervention. I mean, does it work? Usually requires quantitative comparisons between your control group and your intervention group. Qualitative, but may help you understand the process by which you get from introducing the intervention to getting those outcomes. Or you may use the qualitative to explore the implementation steps, generate a conceptual model, and then confirming those steps.
10 minutes. 10. I think you mean implementation, 10 minutes. Is that okay?
Yeah.
Boy, can I tell you?
But not according to my watch. You may use the quantitative to focus on content, the qualitative on context, or one of the things about qualitative methods is that it incorporates the perspectives of the people you're studying, your study participants. Because in all implementation research, and it should be the same in all research, they are collaborators, they're not subjects. And I try to use the term participant rather than subject. Whereas the quantitative methods often, are essentially validating your own worldview about how things should work. The qualitative may validate that worldview or may give you an entirely different perspective. So just to give you an example of how this works, I was involved in a randomized control trial of 3 different types of evidence-based practices for treating depression, anxiety, and behavioral problems in 8 to 13-year-olds in community mental health settings. This was a study done in Boston and in Honolulu, and talk about 2 very different settings. But we were looking at, in particular, whether using an evidence-based practice, the way the practitioner or the way the researcher develops this, which is, very thick manual, how to treat depression in 8 to 13-year-olds using cognitive behavioral therapy and 12 not-so-easy steps, to a modular approach, which was, well, maybe you don't need all 12 steps. And in fact, most practitioners don't really treat depression in kids using all 12 steps. They may decide a particular kid only needs 5 steps or 7 steps, and then picks and chooses. Well, this approach, developed by Bruce Torpeda at UCLA, was really designed to look at giving you some guidance on how you pick and choose, because they knew that's pretty much what clinicians did, but let's make it a bit more systematic. So they wanted to compare the effectiveness of 3 approaches: usual care, a standard manualized approach to treatment, and a modular manualized approach to treatment. And then conduct both a process, my involvement in this study was looking at the process, the effectiveness trial, and the implementation. And so we went through a series of studies, beginning first with a study that I did that involved interviews and observations in the clinic, talking to clinicians, participating in the training with them, and generating a model of what I thought were the determinants of implementing what they really wanted to implement, which was the modularized version. And so we came up with a set of pre-implementation characteristics like You know, what kind of training did they have in graduate school, how ready they were to implement, how open they were to participating in the randomized trial, to the kinds of interactions that occurred between the researchers and the clinicians, to the long-term supports that they were getting both from the research enterprise as well as their own organizations, to the decision that, you know, I kind of like doing this, but I'm not going to do it with every patient, or I like this, but I don't like all of it, so I may use all of it, some of it with all of my patients, all of it with some of my patients, you know, but the idea being that I was not going to use the standardized approach. Now, as I was doing that, simultaneously, the rest of the research team was collecting and analyzing all of the outcome data. So which of those three made a difference? And what they found was that the modularized approach produced the best outcomes. It was more effective than the standardized approach, and perhaps disappointing to some of the people who generate these standardized approaches, the standardized approach wasn't any more effective than treatment as usual. But the question was, why was the modularized approach effective? And I did a follow-up study after the randomized controlled study, 3 months after that, you know, the study ended. And I found that 93% of the therapists that we trained, whether it was in the standard or the modular arm, continued to use the evidence-based treatments. But 93% of them, even most of the people in the standardized, used them in a modular fashion. And the reason why, through the qualitative analysis, is because it facilitated more exchange between the researchers and the clinicians. And I refer to it as a cultural exchange in the sense that both researchers and practitioners began to develop a common understanding about how you treat kids in these settings. So the researchers learned something about it and began to do something differently as the basis of what they learned, in much the same way that the practices of the clinicians changed as well. So another form, and I'm getting close to the mark, is social network analysis, which is also increasingly being used. Now, you can imagine, again, from that graphic of the diffusion of innovation of hybrid form, that how people are connected to one another and how organizations are connected to one another is very important. And so when you think about the connections, it's not just, am I connected to Milton or to Claude, but in what way am I connected to them? And how connected am I? All of those can be quantified. And that quantification can occur through a variety of data, including questionnaires, direct observation, written records, or archival information, experiments, or derivation, drawing conclusions. This, you probably can't see it from the back there, this is the social network of Jesus Christ. And all of the members of his social network as identified or described in the Bible. Now, as you can see, connected to some people a lot more than others, like the Apostle Paul or the Apostle John or Matthew. Some like Thomas, the doubting Thomas, he's kind of on the end there. And then there are some people, who are in the Old Testament. There are connections, but it's not like Jesus ever met them. But the linkages that are defined in the Bible. So that's one example of a social network. But we've come to realize that social networks are also important in understanding the process of implementation, because we know from health behavior studies that if you are obese, the chances are pretty likely that people you hang out with are also obese. Or if you're engaged in a lot of physical activity, the people that you interact with or connect with are also engaged in that activity. And so not just with respect to individual health behavior, but how organizations themselves behave and their willingness to implement and adopt. So we tested out that theory in a study that we were doing that involved implementing evidence-based practices dealing with the mental health and behavioral health issues of kids who are involved either in child welfare, juvenile justice, or child mental health. And we connected information from 176 different providers of those services in 40, well, this was actually in 12 counties in California, and then charted their connections and their social networks. And you can see in some instances the networks are fairly small, but that most of the people involved were connected in one giant group, one way or another, and they were all connected by virtue of an association with one particular person who happened to be someone from the California Institute of Mental Health who had worked in the field of child welfare and juvenile justice for several years, so a lot of people knew him. What we found, however, is that the size of that network, the size of a network, predicted how far along they got to implementing this evidence-based treatment known as multidimensional treatment in foster care. We also found that a significant independent predictor of how far you got was the extent to which other people came to you for information and advice. Now, of course, that makes sense. If you're doing it right, other people want to learn from you. But the point being that the extent, not just the fact that you were successful, but the fact that other people were coming to you for information and advice was an important predictor as to how far along you got. We also implemented a strategy to implement known as community development teams, where people were interacting with one another. And we found that the people who participated in that intervention, the community development team, were all linked together, even though they may have been in different groups, that they somehow were able to find one another, which was one of the aims of the community development team, to build networks of people who could problem solve, share resources, exchange information. Whereas under the control condition, which is how people normally learn about evidence-based practices, you had one fairly large group, but then a number of smaller groups. And we found that, again, the community development, the strategy did what it was supposed to do. And by virtue of doing that, it was able to much more successfully implement the intervention than the control condition. I'm going to end with this final description of experimental and quasi-experimental design. By talking, again, as I was saying, the randomized control trial, which we typically use, may help you understand, is my intervention efficacious? But it won't necessarily tell you, is it effective? And the reason why is, when you're talking about a complex intervention, it's when the outcomes are nested within organizations. It's not, my sample size is not the number of patients I'm seeing, it's the number of clinics that those patients go to, because implementation usually occurs at the level of an organization. So it may have limited external validity, not generalizable to other clinics or other settings. People in communities or clinics don't like being put in a control group. Not surprising. But there's the ethical issue. If I'm really convinced this is going to work, am I going to not give it to half the population? And they may not want it. It's either all of us or none of us. or it may not even be feasible to do the randomization that way. So there are a number of alternatives to doing it. One is called the dynamic waitlist design, where you randomly assign the units to different times for training or the intervention. And since it's at random, you can get pre-post data from all of the units and then do both within and between group comparisons. But it helps you also understand whether the intended changes occur across time or conditions, which gives you greater statistical power for a smaller N, easier to implement, and addressing the external influences in the environment. So in that study of the social networks that I was describing to you, we studied the first cohort of a 3-cohort study. It ended up being a 4-cohort study because to increase our power, we ended up going to Ohio. And we started with 40 California counties. Now, when you train people in any intervention, it's hard to train everybody at once. So logistically, it makes more sense to train, say, 12 counties than 40 counties at the same time. So we randomly selected 12 counties. Everybody else got put into a wait list. They became randomized to the second cohort with the remainder of 13 counties waitlisted, who became the third cohort. So you have randomization, you just don't randomize everybody at once. Another one that has become increasingly popular is what's called the step wedge design, where the timing of the crossover is randomized. Everybody gets the intervention. It's just when they get the intervention. Again, it creates an opportunity for pre-post comparisons, so you can do within subject or within organizational comparisons as well as between organizational comparisons. And then finally, I'll end with this, which is a hybrid effectiveness implementation study, where you can do, basically, to do implementation research efficiently, you do it at the same time that you're evaluating the effectiveness of your intervention. So many times these are referred to as implementation effectiveness design. But they can focus more on testing the intervention, evaluating its effectiveness, and just collecting information on barriers to implementation, in which case it's a type 1. Or you can have, pretty much convincing evidence. You've got a successful intervention. You want to focus on testing the effectiveness of the strategy to implement it, in which case it's a type 3. Most of them fall within the middle, where you're both simultaneously figuring out, does it work, and what do I need to do to make it work? So I'm going to stop there. I actually had more to talk about. Well, I'll just maybe do the community-based participatory research. You're all familiar with that. You all pretty much know what it means. Again, it's not just a matter of collecting and analyzing data that you develop these partnerships, but how you engage them in using the data to make effective changes. So I'm going to stop there and take any questions. So, your mind. Yeah.
So, how do you, I started thinking a lot, how do you know, how do you start thinking about whether you need a theory, a model, or a framework, or multiple? How do you go about choosing one?
Yeah, that's another $64,000 question. How do you go about choosing one? Well, so the fact is that both the determinants and the outcomes have to be specific to the setting in which you're conducting a project. It may be, for example, that you've got, you're evaluating a program that's already got a pretty good funding stream or has already got sufficient demand, where the external environment isn't all that important, in which case you may want to select a theory or a framework that focuses more on what's going on in the organization. Diffusion of Innovation Theory, for example, focuses on the intervention and the action. It's less concerned about the organization. It's less concerned about the external environment. If you realize that this is going to be a process, this is not a point in time investigation of a particular phase of implementation, but you're going to map that entire story of how it happened from beginning to end, then the EPIS model or other models that emphasize the stage or phase nature of implementation would be something that you select. So that, and it may be, for example, that features of frameworks that focus on networks become more relevant. Not all of them do, you may select a framework based on how much attention it gives to the role of networks plays, because networks aren't necessarily relevant to every situation or every context or setting in which you're trying to implement something. So you may want to select on the basis of that, on the basis of what you might see on the ground, or what you might see empirically as a element that you need to focus on.
And a related question is there a good resource for, I find it very helpful to have the figures to see what each model to see them visually. Is there a resource where you can say, I'm really interested in the whole process, and so I need these components, or is there some sort of database or something that you could use, or is it literally, I guess I'm wondering how you.
There are databases that are available that help you that provide some guidance to selection of frameworks as well as selection of strategies. So there's one called ERIC, and I'm not quite sure what ERIC, the acronym stands for, but as I said, there are dozens of strategies for implementing, and then the link between the strategy and the theory or the model for doing so. And you can search through that, and that will give you some guidance.
And I would add, because I'm reviewing grants right now for the implementation and dissemination, it also is important at times, for example, if you're working with something that has already used a model, to figure out, or a framework, to figure out what are you bringing new to that model or framework. Because it could be that it's not only what you can use, but if there's something that you can advance the implementation time. So oftentimes somebody has already implemented some of what you're doing, and you may be looking for a special population, a more vulnerable population, and perhaps looking what's been used before. Is there a way for you to build onto that model something that has not been done before? That also can be a very strong application.
Yes.
Thank you very much for the very nice overview. One sort of technical question. You gave me 4 pillars in the beginning, and you talked about theories, models, and frameworks, and then you started talking about mixed methods and social network analysis, et cetera. Does that come under one of the pillars?
Yeah, the methods. So the 4 pillars are, the theories, models. That's one pillar. What gives us the guidance. The strategies that we use to implement is another pillar. The 3rd pillar is the methods that I've talked about, like mixed methods and social network analysis. The final one, which I wasn't sure I was going to have enough time to talk about, is the measures that we use. So we have developed, as I said, some standardized approaches to measuring implementation outcomes. One of the most common used approach is what's called the RE-AIM framework. RE-AIM standing for reach. You know, how many people that are eligible for an intervention do you actually get in touch with or engage with? E for effectiveness, does it work? A for adoption, can you get people to use it or interested in using it? I for implementation, are they using it with fidelity, the way that they were trained to use it or the way that the developer had intended it to use? And M for maintenance. So that people, as Milton was saying, when you submit a research grant, you want to demonstrate, that you actually are doing what you claim to do. And the RE-AIM gives you a set of outcomes to look for that will demonstrate your success.
So, if I may, the other thing the non-technical thing is, so I think everybody here struggles somewhat with the boundaries of, what's implementation and what's effectiveness. And sometimes I feel that because implementation science is so popular a term right now, that there's a little bit of creep into doing a study that really should be more like an efficacy or an effectiveness study, but calling it implementation because that's kind of a sexy thing to do now. I really like the hybrid design because I think it speaks to that explicitly, but I wonder if you share what my observation or if you think that's not.
Well, I think to the degree that,
And what I mean is that people take, here's an example, we know PrEP is effective, but we don't know is that the innovation, or is the innovation how to get people to take it up? So if you're studying if you think we don't know how to get people to take it up, so that should be an efficacy or an effectiveness study, right?
No.
But
Knowing that it works would be efficacy or effectiveness. Knowing that it works, like say if you introduce PrEP in Mozambique or Uganda, that would be an effectiveness study. Getting people to take it up would be an implementation study. Or getting clinics to work with patients or clients to take it up would be an implementation
that might be an effectiveness study.
So I think that, no, but one second, so let us explain.
We don't know it works in the population.
So let me say something a little bit. Because one of the issues that we all have in our training, except sociologists and anthropologists, is that we think on one-on-one. So efficacy studies tend to assess the one-on-one, is Milton taking PrEP? Is he using PrEP? Is he getting infected or not? Efficacy. When you do effectiveness, even sometimes, it's not about the system. It could also be, you put it in a clinic, is it being used? But when you're talking about system-wide, you cannot use efficacy and effectiveness. You need to start talking about implementation because it's about much more the relationship between, quote unquote, the provider and the recipient of the intervention. So the adoption of things is not efficacy. It is about implementation. And that's what it's been lacking. And that's the problem because many things we show the internal validity, it works, but we do very little in trying to make sure that clinic systems use it. And that's a big difference.
Go ahead.
All right.
Brian.
I want to make sure I'm clear on this distinction too. So if you're studying an individual's adherence to PrEP, then it would be an effectiveness or efficacy trial. But if you're looking at getting clinicians to prescribe PrEP, then that would be
yeah. That would be a good example. Yeah.
Kind of related to that, I feel like a piece that always, that everybody struggles with how to make things sustainable and long-lasting.
Mhm.
The implementation trial is over. So I'm just wondering if you have any suggestions about that.
So, depending upon, Claude mentioned, I've been working on a study that's developing a measure for sustainability of programs that are funded by SAMHSA. So as you know, SAMHSA funds a number of HIV programs. They fund programs in substance abuse prevention, in mental health, like suicide prevention, the Garrett Lee Smith programs. And one of the things that we found is that depending upon the nature of the program, some things may be more important than others. Some of these programs are explicit in saying that if you want to get funded, you have to develop a coalition, a group of partners. And in fact, for some programs, they have to be very specific types of partners. Now, that's true with some programs, like the State Strategic Prevention Framework, SPF, state implementation grants. Less so in others. So one of the programs we evaluated is a mental health prevention program in schools called the Good Behavior Day. Their coalitions are less important. Depending upon the nature of the program and the settings, coalitions could be important. Alternative sources of funding could be important. It can be, for example, a lot of these SAMHSA programs, the organizations that are funded by SAMHSA, as soon as one funding initiative goes away, another one appears, and they apply for money to do that. So they keep doing what they were originally funded to do, but now in a different context or variation. We've identified 6 different determinants. In fact, I think I can show you, probably. Yeah. Of sustainability, of being responsive to community needs and values, and not just, addressing the important need, but doing it in a culturally acceptable way. By that I mean, does it meet the expectations of the people you're working with? Do people see it as a high priority, not just a need? Do they value their relationship with you? Coalition partnerships and networks are an important predictor. Alternative sources of funding depends on the nature of the organization. It may not be a predictor for some programs than it is for others. Leadership support and having a program champion is important. These are all predictors of sustainability of these prevention programs. And then continuing to monitor your outcomes and evaluate, are we still making a difference or not? When you stop, when you realize you're no longer making a difference, that kind of reduces the motivation. And it kind of gets back to the question, or the comment that you made about drift. The reason why we often look at effectiveness and implementation together is people are more inclined to implement something that they can see works. And if they have evidence of effectiveness, that becomes a determinant of implementation. Yes?
I have a question about if you have a framework or approach when there are multiple interventions in one setting that you want to evaluate at once. To give you a concrete example, at our HIV clinic, for example, the last few years there's been an incorporation of different systematic changes, right? And all of that responding to different city and governmental pressures. So like people saying, okay, we should put a focus here now in terms of our HIV care. So now there's been maybe 3 or 4 different things that have happened over time. That's under this label of practice transformation. But if I was to try to evaluate how that has impacted, let's say, our outcomes for our patients in that clinic, what would your approach be to dealing with different, different interventions happening over time?
So, yeah, you're right. I mean, we rarely implement just one intervention. we're dealing with many, more often than not. There was an effort in LA County, for example. The Department of Mental Health wanted to implement a half dozen different evidence-based practices all at once. And logistic challenges involved in, having everybody trained, and trying to keep their heads straight. So what am I learning now? Today's Tuesday, I must be doing trauma-focused CBT. Wednesday, seeking safety, but so that's where a focus on the organizational constraints, because each one of those requires a certain set of resources to support. From the perspective of the individual provider, it's a matter of timing, right? And so do I really have, in the amount of time that I've got available to work with this client, the opportunity to deal with both their traumatic stress symptoms as well as their depression or anxiety? How do I make those decisions? What is it that my clinic is providing me that can support me? Is there a champion who can, provide resources when I need them in a timely fashion? So it's not just a matter of looking at the individual provider, but it's really looking at the context or the organization in which that challenge is occurring. And as I said, one of the things about implementation is the complexity that's involved in that. And that's why we've been now moving more towards not just social network, but system science. Yesterday I was in St. Louis on another project grant, center grant that I'm involved in. I'm listening to a presentation on agent-based modeling, which is now becoming very popular in public health as well. It's a way of understanding how, what motivates health behavior change and how can you model those changes. It's also being increasingly used in implementation science as well, because it can help you chart, all the changes that are occurring, not just with respect to one intervention or practice, but a multitude of them at the same time.
I can add a follow-on question. I think another thing that relates to a follow-up question is then how do you go about evaluating the effects of an intervention if what you're relying on is pre-post data and all this other stuff is happening? I mean, that's the real world, but how do you handle that analytically?
Well, pre-post data in any setting is only going to give you limited value in terms of what you can understand. That's particularly where mixed methods would be of great use, because you get a much better handle on the complexity of what's going on around you, that you can then begin to pinpoint which things you need to control for quantitatively and which order you need to control them. Yes.
Originally, young investigators were encouraged to ask questions. So, and I think, if we are going to do a study or be a PI or a pilot trial, so could you speak at all to, how implementation science methods and frameworks and measures can be used in pilot trials? Is there any unique circumstances there dealing with much smaller people? And then also, not just that, but also how can pilot trials be used effectively to lead the implementation science studies?
So, certainly in terms of pilot trials, you've got fewer resources to rely on. You have to do something that is cheaper, faster, less intensive. In fact, I was going to end with this because...
You find a way to get your slides in, right? Great.
That's cool.
Yes.
I was going to end with this because there's an opportunity to get trained in this here in New York next February. We've struggled with this. How do you raised a question earlier about the fact that this is very time intensive and labor intensive. And so, particularly in a pragmatic trial, where you're conducting research, if you're funded by Picori at all, you're doing a pragmatic trial. We developed an approach to collecting qualitative data in a mixed method context in an implementation trial. This was based on implementing evidence-based screening for trauma and alcohol use in emergency ED departments. And this really involves a way of collecting and analyzing qualitative data that involves more than one person. The person collecting the data, usually by being in a site visit in a trauma center, and a person like myself who may not be there but can be there to bounce ideas off of, to participate in the process of understanding and interpreting the data. This is something that can be used in a pilot study setting because it gives you exposure to the study site and enables you to collect data. And the reason why I mention it is because I'm also a co-director of the Methods Core of what's called an Alacrity grant. It's NIMH funded. And one of the PIs is based at NYU, Kimberly Hoagwood. And I'm going to be coming out in February to do training of her staff in how to use this method. But I figured part of it will be a little field trip down to the trauma unit at Bellevue, because they've got a project going on there. They want to implement a abbreviated form of screening for suicide and depression in children and adolescents who present to the clinic. But part of my training will be to take them through and have them observe what's going on in that brief period of time, and then, talk about what they learned during that experience. So, if that sounds like something that may appeal to you, we might consider doing something similar to that in a setting that you're more familiar with. But that might give you the tools that you're thinking about, that it wouldn't require having to spend a lot of money feeding a focus group of 20 people, 8 to 10 people for the purposes of collecting data.
So we have 2 more minutes. Last comment. It's okay.
So thank you so much, because I said this last time, right? It's helpful for me to hear things a couple of times before they click. But one of the things that I think is so important about what you do is it's not so much the topic, but the process of each of these things across them. And so sometimes I think we are all in our silos of what we do. So, I'm an HIV researcher, or I'm a mental health researcher, or I'm a child researcher. I actually happen to go across all three of them. But the fields are really different. But yet what you are applying today in child and adolescent and mental health is so applicable, I think, to what we do. And I guess it's a really important lesson that we need to get outside of our silos, because innovative methods are in other fields. We don't need to reinvent wheels. And so that's what, so thank you.
and I want to add, because I know that implementation science is very young, and when you do trials, for example, in psychiatry, you have very, very restricted eligibility criteria, where you treat people with depression, you exclude people with substance abuse. And then you do substance abuse, you exclude people from depression. And what you do is you're actually working with what is only 15% of the population. And there's another 85% that has a mixture of things. Which means that a lot of the efficacy that we do with very clear populations may not necessarily apply for larger populations, number one. Number two, it doesn't apply to a system. It applies more, again, to the one-on-one and how, our interventions that can be so consuming and require, we do them with very well-trained people. Now we have learned that we can do it, with lay people, and we can do many great things with them. We still at times create eligibility criteria that makes it very hard to be, scaled out. And part of what we bring with implementation science, especially in hybrid with effectiveness and implementation, is how do you really work with the people that are out there? And in HIV research, we have been dramatically fewer when we would do our study. I remember when I was doing my work in Brazil, we wanted to go back to doing efficacy when we have done several studies with efficacy. And I would say, well, if we do a study here at PI, if we move it to Washington Heights, do we need to do another efficacy trial, even if we move 3 blocks away? So there's a rigidity in science, and I'm not saying that we have to be completely soft, but we need to think of how to move science in a faster pace. And HIV made us learn that. Medications were terribly produced before HIV, and now we do it much faster. So it's time for us to do it also in non-medication trials, which are a little bit more complicated. And Larry, it's always a pleasure to hear you and learn from you each and every time, and we'll figure out how to do that here. Thank you, everybody.